Good afternoon, and welcome to today's webinar, Patient Safety Care Enablement Through Clinical Zero Trust, presented by Healthcare Innovation. My name is David Rath. I'm the Senior Editor at Healthcare Innovation. Today's program is sponsored by Medigate, Cisco, and ePlus, so thanks to our sponsors and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, you can join our webinar conversation on Twitter. You can tweet using the hashtag HILiveWebinar. And also the presentation is available under the Event Resource tab on your screen. And at this time, I'd like to turn it over to Ken Puffer, the Healthcare Chief Technology Officer at ePlus, our moderator for today's program, and he can introduce the rest of the panel. Ken?
Thank you, David. Healthcare is under siege from cyber criminals, and many organizations are in a very vulnerable state. Malicious persons are targeting healthcare in several ways for monetary gain, and healthcare organizations may not be well equipped to effectively defend against them. Patient care being their job and clinicians relying on immediate, unimpeded access to medical information. When these systems are unavailable, vital information for patient care is absent, including medication dosing and schedules, which puts patients at risk and interrupts documentation necessary for proper billing. This type of attack often forces organizations to declare a disaster and results in them diverting inbound patients. A successful ransomware attack in Germany forced a hospital to go on divert and is suspected of causing the loss of life of a patient when the ambulance she was in was directed to another facility. Successful ransomware attacks have also caused the delay of critical EHR transitions and loss of revenue. Protecting the network and ensuring system availability is paramount in today's healthcare delivery model. Hello, my name is Ken Puffer, the Healthcare CTO for ePlus Technology. We're here today to discuss how to protect your organization from these sorts of attacks. Joining us today, we have Lee Waskiewicz, Vice President of Security Strategy at ePlus, Jameson Utter, Clinical Zero Trust Specialist with Medigate, and Eddie Madonsa, Security Specialist at Cisco. As Vice President of Security Strategy at ePlus, Lee works with organizations in many industries to hear about the security challenges they're facing, while Lee works with these organizations and security technology providers to align the proper solutions with the organization's needs. Jameson brings 25 years of physical and cybersecurity experience in a number of industries and has presented to the U.S. Congress, EU at The Hague, and major universities on cybersecurity and IoT. He brings this experience to Medigate, a leader in medical device security, and one of our primary sponsors of today's event. Our next panelist today is Eddie Madonsa, a 20-year veteran at Cisco, currently covering cybersecurity technical solutions for Cisco's global security sales organization. Eddie brings a deep experience in Cisco's Identity Services Engine, also known as ICE, a security technology used to dynamically and automatically enforce network security policies and access controls. We're going to start with Jameson, who will lead us through the basics of clinical zero trust. Welcome, Jameson.
Thanks, Ken. First, I'd like to start with a foundation on what zero trust is and how it works. In case anybody's been under a rock for a while, Zero Trust was originally brought forward by Forrester around 15 years ago by then analyst Chase Cunningham and John Kendevarg. The idea is trust nothing but always verify. It seems pretty simple. When we apply this the way they do, it's this idea that we put data at the center of a network, and around it we have other concepts, workloads, people, devices. And it works very well in a data-centric setting. And what I mean by that is, for example, in the cloud, when what we're protecting is a digital asset, an employee record or a health record or credit card information, it works incredibly well for these sorts of concepts. The idea is kind of following what they call the Kipling method, which is who, what, where, why, when, and how. We have to answer these questions about who has access to the data, when they have access, what they're allowed to access, how they can access it, all of this sort of stuff. Hopefully everybody here has a pretty good concept at least of where zero trust begins and ends. But I think it's important to talk a little bit about it and a little bit about what it is not. So what's important about zero trust is regardless of what any vendors in the space have told you, and ironic that I'm a vendor telling you this, no firewall, no NAC, no endpoint security, microsegmentation, none of that is zero trust. Zero trust is really a philosophy about networking that utilizes all of those types of controls to give you a zero trust environment. So it's important to remember that no single technology gives you that. It's an approach to how I handle data, networks, access, and time and identity to those things. But what I want to talk about next is what differentiates clinical zero trust from zero trust. Think of it as a subset of zero trust. So all of the things that would be true in a zero trust environment are true in clinical zero trust with one very important difference. And it's really true of all what are called cyber physical systems. And if you don't know that term, a cyber physical system is that idea of a digital twin. I have a physical device in the real world that is digitally connected, either relaying data, acting upon information it receives, and that itself becomes CPS, or cyber physical system. To protect these things, we have to look at the concept of trust slightly differently. And really, it's around limitations of those technologies that I talked around before. Clinical zero trust shifts the focus from just protecting data and being data-centrically focused to protecting the physical process. And so what do I mean by that? It's really everything involved at the end of the wire. If my controls are able to individually address a device and allow that to continue to be safe, then that could be the center of trust. But typically what we see is that the controls we're using, whether they're NACs or firewalls or endpoint agents or any of those other things, are not sophisticated, quick enough, engineered, working well enough together, et cetera, to really dynamically deal with the environment that we see in healthcare, which is a fast-paced, multiple device, highly mobile environment where digital devices are connected to physical processes. So instead, what we have to do in clinical zero trust is we have to move that idea of where our protect surface is from being just the device or just its data to remembering what it's doing. We're going to protect the physical process in totality rather than just its data. So just a moment on what's involved in that and how I wrap my head around what's involved. Well, typically, cybersecurity folks have traditionally been very focused on this digital process that we see there on the left of the screen. We understand data flows, we understand communications and digital files. But what we also need to do now is we have to pull in the physical process, which is really where our clinicians and biomed engineers come involved. I need to be able to, for example, walk the floor and understand where this patient monitor might move, or this pump, or whatever device we're talking about. What access points might it move around? What path might it take in the hospital? Where might it go? I need to understand all of the physical parameters that the mobility of this device introduces. And then furthermore, I need to bring the business in, because as we begin to become real-time health systems and we start to expand the boundaries of what the hospital really is with remote patient monitoring and telehealth and many of these new expansive technologies, I have to understand now that I have both a digital process to protect, which might be available in the cloud, on-site, off-site. I have a physical process to protect, which is involved directly in patient care and involves mobility in the physical device. But I also have this entire process of how is it billed, how is it accounted for, and even further, how is it run? Some of the AI platforms that are doing scheduling and helping with billing might need access to those devices. So I have to bring all three of these spheres into a focus to begin to understand what clinical zero trust could be. It's about bringing the business, about bringing the physical process, and about bringing the digital process together and creating a trust circle around those. Hopefully that sets it up for you well enough, Ken.
It does. Thanks. Thank you very much, Jameson. So Lee, I'm going to start with you. Who inside of healthcare organizations should be interested in and contribute to developing a clinical zero trust strategy that Jameson went over?
Sure, thanks, Ken. To answer that question, many believe that because it's an IT function, right, that the decision and all of the stakeholders should be just resident within IT itself, and that's really not the case. The start of it is because, as Jameson mentioned, it's a cyber physical device and system that we're looking at here. So the clinical devices that are coming online are being driven by a lot of the clinical and medical staff within the healthcare organization, understanding what type of smart devices and what type of technologies that are network enabled need to be added to provide that enhanced level of patient care, right? Because at the end of the day, it's around how do I improve that patient care? How do I improve that patient experience? So getting those stakeholders to the table is important. Secondly, there's the aspect of security and risk when it comes to this, because of the fact now that these are devices that are typically not under the general control of an IT or a security organization like a desktop, a laptop, a mobile device, or infrastructure device would be. It's imperative that the security and the risk personnel are involved to help to provide guidance as to what types of risk these devices can pose, and make sure that there's processes and policies in place not only for the onboarding of these devices, but what types of regular updates and controls should be placed on them, and then making sure that there's visibility from an operations standpoint to make sure that they're operating as intended and there's no indication of any kind of compromise. And then finally, it is very much a heavy lift to a certain degree from a responsibility standpoint on the IT operations folks. So it's those groups working together to making sure that in order to achieve a state of zero trust, that you're taking into account those that are looking to put those devices on the network, those that operate the network, and then those that are responsible for the security, the risk, and the privacy of the organization. And many times, making sure that all those stakeholders are involved are what we see as sometimes a primary hurdle to getting things moving forward within an organization. And I think once organizations can, look to get identified stakeholders from each of those parties, start to work together in a more regular cadence, have an eye on what the end state is, helps to ensure a smoother transition and a smoother maturation towards zero trust.
Thanks, Lee. One thing that comes to mind as you were going through that is that, biomedical or clinical engineering, are really key contributors to that conversation, as they're, typically have responsibility for, the upkeep and maintenance of those devices and interacting with the manufacturers, but sometimes they're left out of the IT aspects of the security and network decisions. So they're, getting them on board. They typically have a lot to contribute, and along with the actual clinicians, really can provide key input to the IT security teams that are evaluating these technologies. So Eddie, what we're talking about seems to be pretty complicated. How would an organization go about getting started on the clinical zero trust initiative?
Yeah, thanks, Ken. To be fair, it is a bit complicated, but the general practice here with this stuff is to maybe start with industry standard frameworks. I would start with NIST 800-207. That is the NIST architecture for zero trust. Before digging into perhaps a specific vendor. So start with NIST and then take a look at different vendor architectures. I would lean towards vendors that have controls in place for all aspects of zero trust. But before digging into vendor-specific stuff, let's cover a little basics of NIST 800-207. The basic concept there is you have a clear distinction between your data plane, which is your basic network access layer, whether that's wired or wireless or perhaps even VPN, and your control plane, which is really the administration on top of that.
So at the data plane layer, we have our policy enforcement point, which is your typical access switch or wireless LAN controller, or perhaps if it's an endpoint, you can, or a cloud, a native workload, you can do enforcement right on that. And then at the control layer, it's your policy engine, your policy administration, what they call in this the PDP. Now let's pivot a little and talk vendor specific, and obviously I'm with Cisco, so we're going to cover a little bit of Cisco's security architecture around zero trust. So at Cisco, we like to split things into these three buckets we call the workforce, which is all your users and devices, how to provide zero trust for the workforce. And the workload is your servers, if you will, your data center applications, whether they be on-prem or perhaps in public cloud or a mixture of both. And then the workplace, which is really what we're focusing here today on, which is providing zero trust for the IoT devices, anything that's physically connected to the network access layer, okay? Around Cisco's security architecture and what are the products that we layer on top of these for the workforce, it's primarily our MFA solution, which is Duo. Duo does more than MFA, but that's its primary use case, is providing that multi-factor auth. It also does device posture and a few other things. Workload, that's our secure workload product, which was previously known as Tetration. That provides zero trust at the data center layer, if you will, all your applications that are running in the DC or perhaps the public cloud. And then the workplace, how do we provide zero trust for the workplace, at least with the Cisco security architecture? That's primarily our software-defined access solution, which is a combination of ICE, Identity Services Engine, and that network access layer, which is, we don't have to get into specifics, but it could be wired, wireless, perhaps a VPN. So at a high level, that's kind of where you would start, is the architecture, NIST framework, then dig in a specific vendor. But I'd also like to mention that there are a couple easy buttons, as I call them, that are relatively low risk when it comes to impact of operations, and you get quite a bit of value around these controls. So the first is around web security. As you know, one of your major concerns around healthcare is ransomware. And one of the easiest protections against ransomware is blocking that web call. Okay, whether it's the initial web call to the malicious domain or perhaps the subsequent web call to retrieve those encryption keys. That would automatically be blocked with a DNS security, something like Cisco Umbrella, or I know that there are others from other vendors. But it's a very easy control that you can put in to block that malicious traffic from the outside. Another easy control, I talked about it with Duo MFA, is add MFA to all of your IT folks. So all the IT folks that have access to critical systems, slap on some type of multi-factor auth, and we can do that easily with Duo, so that they would need that would immediately protect those credentials, because they would need some second factor to log in. So even if those credentials were compromised in some way, we would have a second factor that we could rely on there.
Thanks, Eddie. There's some great options there. Early on when I first started here, I was, I mentioned the fact that clinicians need, immediate and unimpeded access to those systems so that they can care for patients. And these seem like a couple of options, between Duo and especially Umbrella, where, that can be put in, one of them has an end user component to it, but the other, being Umbrella has none. It's effectively, it's transparent really to the end user. The only way they notice it is if something that they were trying to do that was, had become malicious would then get blocked, but it wouldn't affect their normal day-to-day activities.
Yeah, that's a good call out. I would add to that even the headless device is protected by Umbrella. So if a headless device, something like a webcam or a printer or something like that, gets compromised, and the underlying OS is typically Linux on those things, and an attacker tries to run some payload, even those headless devices are protected because there is no agent with something like that, right? It's at the DNS layer. So when the malicious code tries to make a call to a malicious domain, that's when things get blocked.
Right, the malicious domain, command control server, those will get, captured and blocked. So we've got a pretty solid foundation for zero trust. How do we take into account the clinical aspects, the part that introduces risks to patients? Jameson, do you mind, diving into that for a couple minutes?
Yeah, absolutely. I think that's the part that's tricky. I think most folks understand the idea of data protection, but I think sometimes we get lost in the weeds, and I think that was an excellent example of some simple controls that can help us. And I just want to start out with the first point that there's a lot of chatter in the industry about lateral movement over IoT devices or medical devices or compromises in medical devices, and I'm not going to go out on a limb and say it's never happened, but I'm going to say I've been around the industry a long time and I've not seen it. But what I do see is that these nurses' workstations, control stations, MRI machines, other things, they are typically just Windows workstations. They become compromised in some way because the payloads of these ransomware attacks and other common viruses are destined for them. And then in some cases, that renders the device at the other end inoperable, like an MRI machine, for example, or a nurse's workstation that perhaps is the patient monitoring console. Now I can no longer monitor my 50 patients on my floor. But even furthermore, sometimes those payloads themselves detonate on a device. And so what I mean by that is the device has certain ports or other things running that were vulnerable to the exploit that was used on the desktop, but the payload wasn't really able to execute properly. So it causes the device to be inoperable or inefficient or perhaps even worse, unpredictable. And so that's the need for clinical zero trust, is to really separate these devices and these environments from the kinds of devices that are more vulnerable. So then as we kind of zoom back for a second and say, what does that really look like? If we take a care protocol, for example, around a certain procedure, the first thing we begin to do in clinical zero trust is understand what's involved, what is here, what devices are connected. We should know from our care protocols what is done. Often those are all the way down to the gowns that we give the patients. We don't need to know that for clinical zero trust. I just need to know about connected digital twin devices. So once I get to that stage, I understand what is involved. Maybe I have a patient monitor or an infusion pump or other things that I'm going to be using in this process. And then maybe once the patient is rolled into the operating area, we have 2 or 3 other devices that might interact with them, a drug device or other types of monitors or whatever. And maybe the robot that does the surgery. This creates the circle of trust. These devices will not compromise each other. That is not how that works. They're going to be compromised from the outside. So what we need to know next then is the pathing. And what I mean by the pathing is twofold. One is the digital path. And the digital path is what do the devices talk to or need to talk to and which direction. So what I mean by that is some devices are monitored purely. They take information about the telemetry of a patient and they send that to another place where it is analyzed. The device does not receive information from that station or endpoint. It merely sends information one way. Well, that allows us to make a one-way rule. No one can talk to this device. The device just talks to people. This is a great rule. Some devices might receive two-way information with something, a little bit more complicated. But what we can do is narrow down what it can communicate on. They obviously don't need unfettered communication to each other. They use some sort of protocol or procedure or process to speak to each other on a known port protocol standard. So we want to create rules then around that are limited to the necessity of that communication. And then because we have a digital connection to a different system, so for example, if we talk to a nurse's workstation, we need to know what does it talk to as well. That tells it whether it's in our circle of trust or does it lie outside the circle of trust. And so what I mean by that is devices within the circle of trust have no relationship to each other, they don't speak to each other, and they also don't really speak to outside systems but one way. So the example of a patient monitor, it might take information from a patient and send it out to a nurse's workstation or something like that, to the call system. Excellent. One-way communication, that device can be in the circle of trust. But another device that might speak to a device that speaks to the internet, for example, perhaps that station that sends information back in to do some sort of action to a patient, now I've opened that circle. So sometimes easier a little bit to whiteboard the idea, but the idea is I have a circle in the center that these devices speak out, never in. That's what creates our center of trust. The center of trust is devices necessary for the patient. Think of it as a patient area network, if you will. These are the things that are connected to this care protocol in this patient. They speak out to things on the outside. Things on the outside might have different levels of trust because they might talk to other systems, they might talk to the internet, and so we use different controls for them. Then the next layer of trust outside of that is, of course, those systems and the systems they talk to, EMRs, nurses' call systems. So once I've understood that picture, and I know it seems really complicated, but you have to use a technology that can see, first of all, at a detailed level, how those communications transpire, what those devices are, what their functions are. Then I need to take the next step, which is to physically map them. And that seems like a pretty daunting task, and it can be. And so what I mean by that is, really, when I've done this myself, is I got to walk the halls. I need to know what access points, what physical pieces of networking gear, where these devices actually go and can go within the hospital. So for example, I don't want to span a VLAN across 22 facilities because this device doesn't move across 22 facilities. It just moves across these 9 rooms. So I want to be able to make my controls as both succinct as possible and as detailed as possible. And that requires me to understand the digital and physical footprint of the device traffic and flow. Once I understand that, I can begin to create those policies I started to allude to. I understand the timing and nature of communications between devices within circles, inner, outer, exterior circles of trust. Then I also know which controls to apply to which mechanisms. So sometimes NAC is a great mechanism. ICE, for example. I can use that to decide which devices can get on or not on certain networks, which VLANs they go to or not go to. And then furthermore, I can use firewalls, for example, to cut off certain areas and create those actual circles of trust or zones. Cells, as we call them in IEC 62443, a cell of trust for network, for operation, for data, for nurses, for other places. This allows traffic only of certain types to get in and out of those networks. So for example, if other controls fail and that nurse's workstation or call system gets contaminated and hit with ransomware, my downstream devices are not touched. I still might be denied access to them, but they physically can still work. They won't be hit by that shrapnel that I talked about initially. Once I have an idea of what all of those things are, I understand what devices are here. I understand the pathing of those devices, both physically and digitally. And then furthermore, I've engineered these policies, and I want to take a second and key in on that word I just used, engineer. I don't say design or architect, because a key component of cyber-physical systems is that they work the same way every single time. A patient monitor will always communicate the exact same way. No one surfs Facebook from a patient monitor. They don't suddenly load a new game, right? It's not a user desktop environment. These devices are like toasters. So because of that, I can actually build policies, whether they be firewall or NAC or other control systems, it doesn't matter which mechanism we use, that are repeatable and deterministic. And they should work perfectly every time. And the next step then speaks to that. So how am I certain that I have deterministically created those policies? I will monitor them. So rather than just pushing them out and hoping for the best and maybe disrupting patient care, I will monitor that this policy is correct, that it didn't communicate somewhere I didn't expect, that I did in fact understand all of the access points it went to. I did know the boundaries of its communication, right? And so once I have established my policy is solid, is correct, is viable, then I will automate that into my system. In the world of highly dynamic systems and this nearly 30% CAGR growth of device utilization, we must leverage automation in order to both recognize devices, categorize devices, secure devices, and respond to those security events with devices. So now I'm going to push those controls and systems out into my network across my NACs and my firewalls and my endpoints and every other thing I'm using for my zero trust posture, automate that policy push, and allow those devices to become part of it. And ultimately, to even maybe broach a little bit of a question asked before, is that though this seems complex, ultimately zero trust is less complex. The reason is I'm using a consistent philosophy and engineering principle across many controls. Instead of trying to use a single vendor's way of doing things or that vendor's way of doing things, right? I'm using the NIST way of doing things or the zero trust way of doing things. And this allows me to bring on more devices more rapidly. So hopefully that answered the question.
Yeah, that was excellent, Jamison. You know, it caused me to think of scenarios where, you know, knowing how dynamic healthcare organizations are with both the types of devices and the changeover in devices, it sounds like this can actually simplify that process of deploying devices. You know, as you said, engineering the back end, the security profiles, you know, and access controls. Then as these new devices come in that are in that same classification, they can be more easily added to the network and in a secure way, and really be, you know, ready to go right away without a lot of, or in a lot of cases, any interaction with the security operations team or network teams. Would you agree with that?
Yeah, absolutely. Yeah, the complexity or burden of zero trust really happens on the front end. The rewards are reaped on the back end. Once we're in that posture I described, we can onboard new devices almost at will with very little friction to the security process now. It's an enabler.
Yep, it's an enabler. Thank you. So, Lee, if an organization wants to get started on this journey, you know, we've described a lot of, you know, different situations and technologies. You know, where do you think they should begin?
Yeah, just, you know, as you stated, it is a journey. As Jamison mentioned in the onset, right? You can't go to a store and buy a case of zero trust off the shelf. It's not one specific product or one specific solution, but rather it's the culmination of a few different things based on your environment that are helping you to subscribe to that philosophy and ultimately hit that outcome and that goal. So in order to best begin on that journey, as with anything, it's important to baseline and assess where you're at today. So the ability to, as we offer with ePlus, to have some various assessments and workshops, whether that's security focused, to help understand, you know, from a risk standpoint where your alignment is from a security framework perspective, maybe alignment to various security principles or standards that you have to maintain in your organization, just to get a baseline of where some of the priorities fall from the risk and from the security side of the house. And then kind of painting that picture as it relates to driving infrastructure forward, because a lot of the technical components that were mentioned are items that both sit directly on the network or interface with the network as these devices are connecting. And then being able to craft out the proper roadmap, identify any obstacles, inconsistencies, or challenges that an organization would have to face. Maybe there's aging network gear that's there that is not going to be able to support some of the technologies that you're looking to instantiate here by adding these clinical devices to the network. Maybe there's network management platforms that are not going to be able to provide the interface and interoperability from an automation standpoint. And then I think clearly what organizations need to do out of the gate is gain that visibility, which is what the Medigate software helps to provide there, which is, you know, tying into the network traffic that's there today and then being able to use that as the guidebook to lay out, here is what the environment looks like today. And then as part of this exercise, you can start to gather that data together and then map out the policies that you want to have going forward. And that's the critical path to success here. Is it's not just about getting the data. It's not just about trying to put in the technology that's going to help gather enforcement, but rather it's making sure that the stakeholders involved from the onset are seeing the impact, seeing the benefits that this clinical zero trust methodology is providing, mapping that back to the business, and then being able to show those metrics upwards throughout the organization, perhaps through to executive boards, through to auditing firms, through to third parties that are interfacing with that organization. But really it starts with an assessment and baseline of where you're at and properly laying out the roadmap and being what we see a lot of customers. You have to be really honest with yourself as to where you stand. It's not a good spot to kind of be covering up for things that you know or have been swept up under the carpet for years and years. When you're taking on something like this, it's a new, fresh approach, and it is going to make things a lot less complex going forward as more and more devices connect. But it's important to set that phase early from a baseline aspect.
Thanks, Lee. You brought up a couple of really important points, that sometimes we forget about, and that's really kind of having the information to be able to report upwards and show that value and make the make the executive and board level really comfortable with the decisions that we make. But I'm gonna one of the things that one of my first bosses used to challenge me with every time I bring in a new technology vendor and, really just kind of see all the shiny stuff, was, he'd always ask me, so what's the downside? What's the stuff that we really got to know to be able to put this stuff in? So Eddie, I'm going to kind of direct this to you. So what are some of the challenges or gotchas, if you will, obstacles that customers might experience on their journey to zero trust? I know that Lee mentioned a couple things, but anything specific that you want to jump in with?
Yeah, let me expand upon what Lee had mentioned, and that is that the problem itself is not solved only with tech. And if you go to any security conference, RSA or Black Hat, you'll see hundreds of security vendors, and many of them are pitching this silver bullet, like their tech is going to solve the customer problems and automatically improve security posture, right? But we all should know that that's not the case. Really, it's really people, processes, and tech, and a fine combination of those things implemented correctly. So as far as gotchas, I would say that's probably the biggest one, is understanding that it's more than just tech. There's people and processes involved. And then speaking directly to tech itself, zero trust itself, and I know that this was mentioned already, but I'll mention it again. It's not something that you can just purchase and implement. It's an evolving journey. Think of it as software development, okay? Microsoft is never going to announce that the next release, the next patch release of Windows 10 is going to solve all bugs in Windows 10, right? That would never happen. Same thing with a lot of other complicated software. There's always bugs, okay? Well, you can look at zero trust the same way. Think of zero trust applied to web security. How are you going to apply zero trust to a nurse's workstation that surfs the web? Okay, it's very difficult, right? Unless you completely eliminate all web access, right? So, how do you guard against that? How do you guard against a nurse's station and a nurse inadvertently clicking a bad link or maybe opening an attachment? Okay, so some good web security is in place there, right? I've mentioned that one already, so let's focus a little more on maybe the access layer. I come from a background of software development and on ICE, and over the last few years, I moved over to a systems engineering, so I cover partners like ePlus with ICE and other access layer products. And ICE is a good example of a product that does something really well, and that is apply enforcement to segmentation on the access layer. So if you have perhaps you want your nurse workstation segmented from your IoT devices and whatever else you have in the healthcare environment, you want those things segmented, and the only traffic allowed between them is traffic that should be allowed between them, right? So you go into ICE and you go into the policy wizard and you configure this policy and you think, okay, it's all good. But how do you know? How do you know that the administrator that actually configured that policy in ICE and configured those authorization profiles and those rules, how do you know it actually works? ICE by itself won't tell you that, okay? What you need is monitoring on top of that, okay? Like I believe it was Jameson that mentioned that Medigate itself does monitoring. If you're looking at more of a network agnostic monitor, something like Cisco Stealth Watch, now it's called Secure Network Analytics, it gets that telemetry from the network access layer via NetFlow. So that's the ways that you can actually apply auditing on top of ICE, is to determine whether your ICE policy is actually is working the way it was designed to, okay? Another good example is around zero trust for the workload. I mentioned it earlier on the call. Cisco, we have a product we call Secure Workload. It was previously called Tetration. That product does its own self-monitoring. So you let it run for, let's say, a week or a month to do its own monitoring of every workload that you have in your data center to determine what is actually talking to what. Okay, then you can turn the enforcement on, okay? And we call that the application dependency map within Tetration. So whether you're talking about the data center or the access layer or perhaps the endpoints themselves, it's important to call out that it's more than just tech. You have people and processes, and it's more than just turning a product on. Like the example I gave with ICE. So you go, you configure it. Well, it's more than that. You need to audit it. You need to make sure that it is behaving as designed because it's only going to behave as good as it was configured. And I hope that answers the question.
Yeah, that was great, Eddie. I really appreciate it. So, Jameson, I know we have a few minutes left, and I want to leave a few minutes for attendee questions. But from a clinical perspective, really same question. What are some of the challenges or gotchas, that customers might face that you've seen?
Yeah, I think one of it is about time and buy-in. I believe one of the greatest challenges that's faced in all cyber-physical environments, and healthcare in particular, is a lack of convergence between what I call the three personas. And really, in healthcare, specifically, what you see are three sets of people with three different job roles. One job role is about digital stuff. That's your IT, IS folks. They care about moving data, right? You have device-centric people, or you could even call them people-centric people. That's clinical engineering and biomed. And so right, they're focused on what the device is connected to, not necessarily how it is connected. And then lastly, you have the business-focused people, which are much more about how is it built, how efficient am I, how are we running, et cetera. And I see the greatest challenge to clinical zero trust or zero trust in general in a hospital setting is bringing the three of them together to get them to understand a protect to enable strategy that allows them to push the business forward, give greater patient outcomes, more ability to onboard, offboard devices more quickly, as we've discussed, and greater safety satisfied through this perspective. But that is, again, a people process problem, not a technology problem.
Yeah, that's so true. So, Lee, just you got the kind of final question for our panel here. Any thoughts on the challenges that you have and how customers might be able to overcome them?
Yeah, the biggest challenge I see is just the customers feeling overwhelmed, right? Because you're talking about a state that just a few years ago would have seemed impossible, right? And as customers, and especially ones that have been in their environments for long periods of time, they understand the technical debt that they've been running into based on upgrades that have been made and maybe mergers and acquisitions that have come along. And there's a lot of complexity to the environments they manage. So going after and trying to achieve something like this seems to be almost insurmountable. But really, that challenge can be overcome by just taking it, as we mentioned earlier, kind of a step at a time, assessing what's there, and then starting to gain that visibility, and then starting to move down the path towards clinical trust. I think what the statement is, and not to kind of preach on fear here, but starting something today is going to get you further ahead than waiting another week, waiting another month, another few months, because we know that the proliferation of devices, of digital elements, of the cyber physical systems and pieces like that, they're going to continue to increase in our lives. We're going to be connecting more and more to our networks. And the sooner that we can gain that visibility, provide that segmentation, have a clear understanding as to what the devices are, who they're speaking to, and what that traffic flow looks like, the sooner that we'll be in a position to capitalize on new devices coming online. That could provide wondrous new elements from a medical standpoint, from a patient care standpoint. We want to be people that can help provide secure enablement to those technologies rather than a hindrance to those. So while it may seem overwhelming, and that could be just a mental challenge, really there are clear steps that organizations can take to start putting things into perspective, start gaining that visibility, and then moving down a path towards enforcement.
Excellently. As we mentioned earlier, these are very dynamic environments, and more recently, some of the newer technologies that are coming online and being adopted by healthcare with remote patient monitoring, say, really kind of changes the dynamic and the role and, the border of the network. So, you want to make sure that, that you're set up for success, that you as, an IT or IT security team or clinical engineering team, are ready when the business is ready to adopt those technologies. So you can get that, implemented and up and running and functional with, little muss and fuss. So we have a couple of questions from our audience. I want to, just run through a couple of them real quick. So one of the first ones, and Jameson, I'm going to tag you with this one. So question that we have is, how could the German healthcare provider that you talked about at the beginning, how could they have protected themselves better from the ransomware attack?
Yeah, the key there would be in a true zero trust environment, even if they hadn't taken the step to secure the clinical devices the same way, in a zero trust environment, they would have had controls in place that likely would have caught the ransomware as it came in, right? As I understand the situation, though I'm not boots on the ground and not deeply involved in the remediation, the lack of segmentation, the lack of role delineation, and by that I mean device role, endpoint role, etc., contributed to the idea that the devices were all kind of bucketed together. So nurses' workstations are treated the same as end user laptops, treated the same as admin check-in, treated the same as medical devices. And so even the basics of having DNS security, having web gateway security, having some of those pieces in place might have prevented the very situation that didn't allow the patient intake in the first place, right? So part of the process is both easy controls, as we've talked about before, the 80-20 rule, but secondly, also identifying the process for what does it take to make this care happen? As I talked about care protocols, right? Like, how do I get a patient in the door? How do I check them in? What does it mean if that's not available? How do I use this device if the workstation's not up, et cetera?
Great. I really like that, that your answer there. And it really kind of feeds well into one of the other questions that came up. So, that being, what's my risk of inaction? What's the biggest threat that I'm exposed to, and does it impact patient care. Eddie, do you mind, jumping in on this one?
Yeah, of course. Thanks, Ken. So I know we've mentioned it a few times already, and that is around some ransomware defense. Ransomware is not the only attack vector, but it seems to be the one with the most press, the one that we hear about the most. And ironically, I believe ransomware is something that with some basic security controls like web security, perhaps IPS, protecting those credentials can be avoided. So far, my discussions around ransomware has been around, the click-happy nurse or somebody that actually is targeted with a malicious URL or malicious payload. But if we go back a few years, you guys might remember WannaCry in 2017, I believe it was, May of 2017. That ransomware was not a payload that was delivered over a link or a malicious attachment. So to the contrary, it was instead of a vulnerable person clicking a link, it was vulnerable software. Okay, so if you recall, it was Microsoft Server Message Block. And Microsoft had announced a few months before, like, hey, we found this vulnerability in SMB, and it can definitely be compromised, so patch your stuff. So I want to point out that good threat intel helps here. Cisco has a threat intel organization called Talos that at that time when Microsoft released the fact that SMB is vulnerable, Talos released the IPS signatures that will detect that traffic. So, so customers of Cisco that were running our IPS and downloaded that signature payload were protected from WannaCry, even though it was a zero-day attack. So that's just another example of ransomware defense that doesn't really play in with web security and vulnerable people. It's more about protecting that via IPS and vulnerable software. So I hope that answers the question.
No, that was great, Eddie. Definitely pointed out a couple of important aspects. It's not just about web security itself, although, typically our users seem to be the most vulnerable. It's rare that it's technology, but, with these zero-day attacks and the way that they're, seemingly coming faster and with more energy, we got to pay attention to those things as well. And it's good to hear that Talos is right on top of that, and we can be protected, right away from those zero-day attacks. As long as we have the appropriate tools in place. So Lee, the last question that I have from the audience here, I know you kind of mentioned it before, but the question is, how do I sell this capability upstream through the organization? So I think they're probably looking for how do I talk about it? How do I get budget for it?
Right, exactly. That's always the challenge that we see, because it's a lot of times coming from the IT organization trying to put the necessary controls in place. And I think one of the main schools of thought here is that it shouldn't be presented as if we do this or else, right? It can't be presented as an ultimatum. It can't be sold on the fear of what happens if it doesn't happen. I think it needs to take shape of, when you're selling it upstream, think of what we could do if we start to pursue a clinical digital trust philosophy and maturity within our organization. Think of the speed at which we'll be able to adopt new medical technologies to help improve patient care. Think of the ways that we'll be able to improve the patient experience, both from a satisfactory standpoint, a speed standpoint, making things more efficient and operate more efficiently within the healthcare system. So many times with these controls, people try and put up the wall of that it has to be done or else. But I think the way that you present it upstream is, think of the possibilities if we gain this new method of visibility and control within our organization and with our environment, what becomes possible then? And that helps open the mind up to leveraging the IT organization, the security organization, as entities that are going to empower the business, as opposed to burdensome to future change and to disruption and to transformation. And many times it takes a third party to come in there and provide that piece of clarity. And that's many times where ePlus has come in to be able to help organizations, is to consult in a fashion where we're providing, third party expertise based on operating in the healthcare industry, operating in other industry verticals that are looking at aspects of segmentation and of admission control, of zero trust, all these technologies that are working together to provide this clear outcome. And many times having that third party perspective helps then to push the recommendation upwards within the organization, get the business units online, get the financial people online, and the stakeholders that can actually have control of the budgets to see, hey, this is something that could empower us to be more disruptive, be more agile in moving forward with a lot of the technology adoption that we have to account for.
Excellent. I agree 100%. So the final thoughts here. Last question for each of you. Seems like ePlus, Medigate, and Cisco, each has a role to play here. So as, if I was the customer, I'm thinking, so what are the next steps? What if I want my organization to start this journey? Who am I supposed to, or who should I reach out to and make sure that I'm talking to the right person, that, that asked for the right thing, that you guys, Cisco, ePlus, and Medigate are going to play together to support my organization? Eddie, you mind taking the first stab at that?
Yeah, this one's easy for Cisco because we're the vendor. We're behind the scenes making sure that partners like ePlus are well supported. So as a customer or a practitioner, you just work with your technology partner. So hopefully it's ePlus. You just deal with ePlus, and then ePlus handles all of the back-end legwork with vendors like Cisco and Medigate.
That's great. Jameson? Yeah, no, that's perfect. Thank you.
Yeah, I think the Medigate's role to play in here is that ability to go beyond inventory and even visibility into actionable insight. We can provide that first layer identification of connected digital assets as well as that digital mapping. And further on to the recommendations and policies that we would push to Cisco for points of enforcement across the board. So we're kind of that glue that lies between the actual physical process and the mechanisms of enforcement.
Excellent. Thank you, Jameson. And Lee, leave you the best for last here.
Yeah, no, thank you very much. All roads a lot here lead to ePlus. So yeah, definitely, please, you can reach out to ePlus. We have a dedicated healthcare practice, so you can reach out to healthcare@eplus.com if you don't already have a relationship with ePlus. We're a reseller and services integrator that has a global footprint, many outlets and locations here across the continental U.S. If you know your ePlus rep, you can reach out to them and directly. And we're happy to work together with our partners at Medigate, with our partners at Cisco, right? We can help you start your journey towards clinical medical trust through things like security advisory engagements, digital readiness workshops, and other pieces that can help ensure that you're set up for success, and that we can take into account anything that are perceived challenges that your organization maybe uniquely has, and we can bring our perspective, our expertise to the table, along with the technology that's provided through these valuable partnerships to be able to help you be successful in this journey.
Perfect. Thank you. And I want to thank all of our attendees today. Hope you found this, this forum beneficial. Thanks also to our awesome presenters. You guys did an absolutely amazing job. Can definitely tell that you are experts in the fields, and I'm really, really pleased to have been able to, to work with you guys on this today. And with that, I think we're going to turn it back over to David with Healthcare Innovations.
Great. Well, unfortunately, that's all that we have time for today, but I want to thank Ken, Jameson, Eddie, and Lee for the excellent webinar. I want to thank the sponsors, Medigate, Cisco, and ePlus, for making today's program possible. And finally, we want to thank everyone in the audience for joining us, and we hope you'll join us in the future for another Healthcare Innovation webinar. And that concludes today's presentation.